complaint said that she was passing out, and the nurse's triage note said patient is faking syncope. So I thought, well, I better go see this one. We better get an EKG. We get an EKG, and she's got a really prolonged QT. I asked the tech, well, there's some artifact here. Can you get me a better baseline EKG? So he came back a few minutes later with a smirk on his face and said, Dr. McHugh, I've got a better baseline for you. Here it is. Right? So I said, what was the patient doing when you got this EKG? And he just kind of smiled and said, she was faking syncope. So sometimes it's worth. She had started some new antipsychotics that were doing this. All right. Here's another one, prolonged QT. And here's a 51-year-old with acute gastroenteritis who had a prolonged QT. And because she had a prolonged QT, rather than sticking her in the hallway, we put her on a monitor. And she started having intermittent runs of Torsade. It's a good thing we had her on monitor. So I made a practice of any time I've got a patient with severe dehydration, I'll just check severe dehydration, not just mild. I always check a quick EKG. And if their QT is prolonged, then they don't sit in the hallway. They have to go on a monitor. There's another case, 42-year-old alcoholic who was having some really, really bad nausea, vomiting, and retching. So we got a quick EKG. The T-wave inversions are old, but what's new is a prolonged QT. So we put him on a monitor, and he started having intermittent runs of Torsade as well. All right. Anything that's associated with a prolonged QT can produce Torsade. Here's a patient that had a history of seizure disorder, and it turned out that her seizures would occur when she developed Torsade. So she doesn't actually have a seizure disorder. She's just having intermittent arrhythmias that are being misdiagnosed as seizures. Right? So be very careful about that. A lot of patients that are diagnosed as having seizures, you need to make sure that they don't have arrhythmias, because sometimes patients with arrhythmias can drop to the ground, shake a little bit, and people will say, oh, that person had a seizure. And in reality, it's just this arrhythmia that's causing hyperperfusion to the brain. One nice pearl I'll give you here also. Here's a 46-year-old woman with episodic lightheadedness, and every time she's lightheaded, the rhythm strip shows this. She's having intermittent episodes of Torsade. We tried giving her some magnesium, and it didn't help. And then we took a closer look at the EKG. The T-wave inversions are old, but what's new is a prolonged QT, and we realized what the diagnosis was just looking at the EKG. All right? Remember your differential for prolonged QT. All right? Most things that prolong the QT by prolonging the T wave. But in this patient, the patient has a prolonged QT because the ST segment is prolonged. T wave is normal, but the ST segment is prolonged. There are only two disorders that cause a prolonged QT by prolonging the ST segment: hypothermia and hypocalcemia. So looking at this patient, once we realize that she's got a prolonged QT, mainly just because she's got a long ST, we just gave her a couple amps of calcium gluconate and her Torsade episode stopped. Right? Here's another patient with hypocalcemia. You'll notice a normal T wave with just a really long ST segment. Another patient with hypocalcemia with normal T wave with just a prolonged ST segment. And one more patient with a prolonged QT, the T wave is normal, but just a really long ST segment. Take a look at how long that ST segment is, and yet the T wave is completely normal. When you see that, just give them some calcium and be done with it. All right? So we talked about syncope for a little while. When you get EKGs on syncope patients, there's a handful of things you've always got to look for. You're already looking for ACS. You're already looking for arrhythmias. Make sure to look for evidence of WPW, the short PR, and the delta wave, the prolonged QT. Add hypertrophic cardiomyopathy to your list. Add Brugada to your list. Okay? So whenever you have a syncope patient, make sure you're always looking at the QT, the PR, Brugada, and hypertrophic cardiomyopathy. Those are four things that oftentimes are forgotten.
Okay, volunteer. Those who came into you with syncope.
Welcome everyone to the EKG case for the week of January 8th, 2012. Got a nice, short, and kind of a neat case that I saw just recently. It was a 69-year-old man that presented with altered mental status. Now some of you may be thinking, what can possibly be interesting or neat about a 69-year-old man with altered mental status, right? Just go ahead and get the CBC, the Chem 50, the PTT, even though he's got no liver problems or heparin, he's got to get a urinalysis, CTLP, start some antibiotics. Just go ahead and put in the white card for admitting this patient to the hospital, right? The differential diagnosis here probably is about 50 to 100 entities long. Just about anything can produce altered mental status in a 69-year-old. So where do you start? Well, I suggest you start with an EKG, all right? And this is a really neat case because here the EKG actually takes that differential diagnosis and drops it down to one thing. Pretty amazing. So take a look at this 12-lead EKG. Now, there's a couple of things you notice. It's sinus bradycardia. The rate's about 50, 55 or so. Not a big deal. There's a first-degree AV block, which is very common in a 69-year-old man. As we get older, our PR interval gradually increases. So first-degree AV block is fairly common in elderly patients. So first-degree AV block, sinus bradycardia. You'll also notice that there's a leftward axis, and that's simply due to the fact that the patient has LVH. He's got an R wave and AVL greater than 11 millimeters. Yep. So I'm not telling you anything really groundbreaking, but what I want to focus here on, just like we did a couple weeks ago, is take a look at the intervals once again. I think the intervals oftentimes get ignored. And I want to really focus your attention on intervals with a handful of these EKG cases, including this week's case. So we talked about the first-degree AV block already, and the QRS interval looks pretty good. But what do you make of the QT interval? If you take a look at that QT interval, you notice something a little unusual. Now, we talked about long QT a couple of weeks ago. We talked about a simple way of estimating whether a patient's QT is too long or not, is you take the halfway distance between two QRS complexes. So halfway here is right around here, and if the T wave ends beyond the halfway point, then that's considered a long QT. In this case, the T wave ends before the halfway point, so that's not a long QT, but I think what you might notice, hopefully, is that the QT interval is actually relatively short. That's a really short QT interval. In fact, the T wave starts immediately after the QRS complex. There's not even time for an ST segment. It just goes QRS right into the T wave. There's no ST segment. This is a relatively short QT interval. And in fact, I'll give you the EKG machine's interpretation up here. You'll notice the QT interval is 340. The QTC, the corrected QT, is 330 milliseconds. When was the last time you saw QTC that was 330 milliseconds? That's really short. So, what's the differential diagnosis for a short QT? Well, it turns out it's very simple. There's only a few things. There's a congenital short QT syndrome. I know you've heard of congenital long QT. It turns out there's a congenital short QT syndrome as well. It's very rare, so I'm not going to harp on that, but it generally occurs in young kids. It is a genetic abnormality that precipitates or predisposes to VTAC, VFib, cardiac arrest, but again, it's very, very uncommon. Second thing in that differential is digoxin toxicity, relatively uncommon also, because not that many people are on DIG anymore, and chances are if somebody's DIG toxic, you're going to see some other type of abnormalities, maybe PAT with variable block or very slow regular atrial fibrillation. Short QT all by itself is not that common, all by itself that is, for DIG toxicity. But in this case, this 69-year-old with altered mental status has the third thing in that differential. It's very simple. It is nothing more than hypercalcemia. Hypercalcemia can produce a short QT and is probably one of the more common causes of a short QT. In this particular case, the patient had a calcium level of 16 milligrams per deciliter, and as you recall, normal is only 9 to 10, maybe as high as 10.5 milligrams per deciliter. So when you see that short QT, Suddenly that differential for ultra-mental status narrows very quickly to hypercalcemia. This patient needs to be treated very, very quickly with IV fluids and some of the other things that you think about for hypercalcemia. But from the emergency department standpoint, first thing you're going to do is fluids, fluids, fluids. I learned back in residency that everybody with hypercalcemia is by definition dehydrated. They need a lot of fluids. Here's another case, 35-year-old woman who presented with a mental status change. She came in very agitated, and once again, the abnormality that hopefully jumps out at you, even if you're using the EKG machine's interpretation, is she's got a very short QT. Look at that QT, it's 278 milliseconds. The QTC is 374. We'll blow up a couple of leads, and you really appreciate that there's a very, very short QT interval in a bunch of these leads as well. So very short QT. We got a quick calcium level on her. In fact, just started treating her with IV fluids, and her calcium came back 17 milligrams per deciliter. Turns out she had sarcoid. So just a quick, nice little pearl. When you see a short QT syndrome, your differential is very simple. Think short QT equals hypercalcemia. Those patients need to be given IV fluids early, and that differential can be narrowed very, very quickly. All right? So hope that was helpful to you, and I will talk to you next week. Take care, everyone.
I think I stressed on prolonged QT quite a lot. Prolonged QT, I have no problem with people diagnosing it. As a matter of fact, you look the ACG and you start looking for QTCM. But with short QT, I don't think I'll stress it. Well, as a matter of fact, I think we miss a lot from short QT. But the treatment hypocalcemia is easy. The one that calcium you give for lactic cocktail, that's easy. But hypercalcemia, stones, moans, groans, psychic moans, and stones. Huh? Stone moan growth, psychic growth, psychic moan. Okay, the guy out there, stones because it brought for medullary hypercalcinosis that's produced stones. Then one more, related to parathyroid. Okay? Start looking for QTC and do not dismiss short QT. How short is short? Huh? How short is short? Less than 360. Less than 350. So aku remember dua number je. 500 and 350. That's two numbers I remember. Huh? We stop at 40 ke? So 41 40. Oh, another 2 months or you can go to other X-ray.
Case 24, a 60-year-old male present with progressive shortness of breath. He has non-Hodgkin lymphoma, is a non-smoker. On examination, he has aspiration of 90 under in air and is febrile. There is reduced air entry and dullness to percussion throughout the left side. HSA is requested to assess for possible pneumonia, effusion or collapse. This is an anonymous chest X-ray. Rotated to
view or view?
View AP erect.
Yeah.
P.
Why you say it?
Sebab dia punya look at the scapula.
Scapula rotated apa?
Scapula.
Ni
PA.
clavicle tidak view the apex lah. Tidak obstruct the apex. It must be
PA.
PA.
Rotated to the right. Good inspiration, exposure, good inspiration and penetration by inadequate exposure. Trachea deviated to the right.
With factoring in the rotation.
Factoring the rotation. Otherwise, pada tracheal strap not thickened, coronal splay normal, mediastinum still
Can comment on this time.
unable to comment on
No.
mediastinum.
Because it's one end, the other end we cannot see. Right?
Breathing, there is homogeneous opacity over the left lung,
You can say a total whiteout. Ingat,
left lung.
left lemmithorax. Left lemmithorax. So the subject today is total whiteout. A total whiteout. Total whiteout. Homogeneous opacification. Homogeneous opacification throughout left lemmithorax.
Otherwise, no
Vascular macular
No.
on the normal side.
normal side, normal vascular
On the right side, vascular macular.
unable to
Huh?
unable to comment on vascularity of the left
The
side.
left tak payah comment because total whiteout. On the right,
No upper lobe diversion.
there's no pleural effusion, no blood constrofinding on the right, right? Tak ada.
Blunted left postal triangle. Otherwise, unable to comment on cardiomegaly also.
Cardiomegaly cannot comment it, right? But is the mediastinum, is the right heart border appropriate or not? Right heart border, was it deviated or not deviated? Factoring in the rotation, I think it's still okay. Still sit central. Because rotated kan, banyak rotated, bukan sikit rotated. Terus sini, buat banyak rotated. So, I think.
Diaphragm.
Unable to
Unable to comment on
left.
left diaphragm.
But the right-
Otherwise, right diaphragm normal with no egg and diaphragm. No extra scene. Unable to comment on left
Boleh?
left cardiac fluid.
Tak boleh.
Unable to comment. Gastric bubble scene. Hilum, unable to comment on left hilum. Hidden area,
Right hilum?
right hilum appear normal. Hidden
Size,
area,
shape, position.
normal.
Normal.
Unable to actually size, position. Unable to compare on
Yalah,
the
tak
left.
boleh lah compare dengan the left, but I think this is normal. Patut tak tanya. Look.
Hidden area, apex, apex left,
Apex, opposite.
left apex,
Opposite
left
related.
left atriohilum, left
Cannot see.
retrocardiac and
Retrocardiac obliterated. This right retrocardiac
normal.
normal. Below the liver, normal. Image soft tissue,
Image skeleton, visible image skeleton normal with no destructive bony lesion seen. Soft tissue
animal.
normal.
So final diagnosis,
Massive left pleural effusion.
massive left pleural effusion. So pleural effusion, massive. Auto white out on the left hemitorrhea.
Mild tracheal deviation may be due to rotation or mass effect from the pleural effusion. Clear left lung, clear left heart border, normal right hemidiaphragm. Patient rotated to the right, large left pleural effusion, obscured left heart border, obscured left hemidiaphragm, normal gastric bubble. Report pleural effusion, patient ID anonymous, projection PA, penetration adequate vertebral bodies just visible behind heart, inspiration limited, 5 anterior ribs visible, rotation, the patient is rotated to the right, airway, the trachea is displaced slightly to the right, this may be due to patient rotation or mass effect. Breathing, there is complete homogeneous opacification of the left hemithorax in keeping with a large pleural effusion. The right lung is clear, the lungs are not hyperinflated, the right pleural space is clear. Normal pulmonary respiratory circulation, the left heart border is obscured by the effusion. The cardiac size cannot therefore be accurately assessed. The right heart border is clear. The thoracic aorta is obscured. The mediastinum is central, not widened, with a clear right border. The left border is obscured. The left hilum is obscured by the effusion. Normal size, shape and position of the right hilum. Diaphragm indicates the left hemidiaphragm is obscured by the effusion. Normal position and appearance of the right hemidiaphragm. The left skeleton is intact with no fractures or destructive bony lesions visible. The visible soft tissue are unremarkable. Extras and reduced areas, no vascular lines, tube or surgical clips. Lung apices, the left apex is opacified, the right apex is clear. Left hilum is obscured, normal right hilum. Behind heart, the left obscured by the effusion. Postophrenic angle, obliteration of the left postophrenic angle, right side clear. Below the diaphragm, normal.
Okay, so the topic is actually total whiteout. This X-ray demonstrates a large-sided pleural effusion, which is likely related to the patient's nerve malignancy, which is the non-Hodgkin lymphoma. All right.
When assessing a whiteout, it is essential to be aware of the possible causes. Causes of whiteout: common large pleural effusion with minimal or moderate secondary compression, collapse of the underlying lung. Large pleural effusion with major secondary compression, collapse of the underlying lung. Collapse of the entire lung, minimal or no pleural fluid, previous pneumonectomy. Uncommon extensive pneumonia involving the entire lung. Extremely uncommon extensive tumor infiltration of the lung. Extraordinary rare congenital absence of a lung.
Of a lung. Okay. Now, for a whiteout, the first two is large pleural effusion. Common one is pleural effusion. Yeah. Tetapi, the determinant whether there is minimal or major collapse of the underlying lung depends on a few criteria. So the criteria when you analyze the total whiteout, first,
First, the key to analyzing a whiteout determining whether the mediastinum is displaced. This requires assessment of the position of the heart and the position of the trachea. Mediastinum displaced to the opposite side, large effusion. Mediastinum displaced to the ipsilateral side, lung collapse. An occasional dilemma, a whiteout but there is no displacement of the mediastinum, and B, the trachea is central.
Okay. So if you got total whiteout, mediastinum displaced to contralateral side, trachea displaced to contralateral side, meaning there is tension, pleural effusion. Okay. But if the mediastinum displaced to the total whiteout, instead of pushing back, you're pushing sini. I commonly see in those inadvertent right mainstem intubation. You intubate right mainstem intubation, causing collapse of the lung. Bukan pleural effusion, collapse. And the trachea will be sometimes deviated or displaced to the ipsilateral side. Okay, Masya?
The most common likely cause, a large pleural effusion associated with or causing major collapse of the lung. The net effect is no displacement. Much less common, an extensive lobar pneumonia affecting all the lobes of the lung. An air bronchogram may be visible. Very rarely, extensive tumor infiltration of the entire lung.
So bila you tengok total whiteout, your differential diagnosis consists of two, which is pleural effusion. Now pleural effusion, you first biggies. When you see total whiteout, pleural effusion, you are asking yourself, is this pleural effusion associated with collapse of the lung or not collapse of the lung? If it's deviated to one contralateral side, you know it is texture. Okay? Then you look at the trachea. Trachea central, mediastinum central, meaning the collapse, you tak boleh ada pleural effusion, you can collapse the lung as well. So when the lung collapse and the pleural effusion's effect are both equal to tracheal central. Okay? And then much less common is extensive lobar pneumonia, but you will see airway program. So, chest exit finding A.
Chest finding A, mediastinum displaced to the opposite side. Large pleural effusion, most likely cause large pleural effusion with minimal secondary compression, collapse of the underlying lung. Trachea central or deviated to the opposite side.
Nah, tolak. Large pleural effusion, okay? And large pleural effusion, actually, when I say mediastinum shifted to one side, I put tension. Tension pleural effusion. Okay?
B, mediastinum central, no tracheal division, large pleural effusion with major collapse of the underlying
So
lung.
the net effect will be tracheal central.
C, mediastinum displaced to the ipsilateral side with trachea deviated to the same side. Most likely causes collapse of the entire lung, minimal or no pleural effusion. D, features of C above and ribs missing, distorted pneumonectomy. The clinical history is
It's
conclusive.
From the history you found.
Exceptionally,
Okay.
those findings may be due to an extensive pneumonia affecting all the lobes of the lung or to extensive tumor infiltration of the entire lung.
Very rare exception. So ni total whiteout which side? On the right side. Trachea displaced or not?
Displaced.
Huh? When the standard displaced or not? What is the three reference points to look for mediastinal shift?
Apa ni? Trachea dengan right heart border. Trachea, right heart border.
Aortic knuckle.
Oh, kita nak.
Aortic knuckle.
Okay.
Trachea, aortic knuckle, right heart border. The right heart border sudah displaced and fall on the vertebral column, you know that is. Provided the chest exit is not rotated. Okay? So, large right-sided pleural effusion. Mediastinum is displaced or not? Displaced lah. To contralateral side. Wiped out. The mediastinum is central, so is the trachea. So, the large effusion associated with collapse of the underlying lung. So, when you write there, a total wiped out of the lung associated with major lung collapse. So the pertanyaan you lah, what do you mean by major lung collapse? Major lung collapse, what I mean is because I see the trachea central and the mediastinum remain central. So the net effect of collapse and effusion is still the same. So hence it will remain the same. So this is what you see. Collapse, but pleural effusion. Trachea deviated to one side. Then you know there is major collapse of the lung. Okay, major collapse of the lung. Tak ada pleural effusion. And if you see macam ni, and you see rib 2-3 rib hilang, you see dekat hilum there will be a lot of stapler, surgical clips, so you know this is pneumonectomy. Another cause of total wiped out. So the official diagnosis of total wiped out will be large pleural effusion, either associated with minimal lung collapse or major lung collapse. 3, 4 will be your major lung collapse. Lung collapse and 4 will be pulmonectomy. So this is, people see this typically if right means that situation. So see, one side. So lung is collapsed. Total whiteout also. Total whiteout. Very rarely lah. Total whiteout. Tapi whiteout dia tak super whiteout. Tak super whiteout pneumonia. Tak macam whiteout pleural effusion. Dia patchy heterogeneous opacification. Dia ada lagi area lucency with air program, right? Ni give you tahu this is extensive tumor or extensive pneumonia. Lobar consolidation. Okay. Ni? Whatever. Today, you go back and increase. Huh? Apa dia? One lung ventilation. One lung ventilation. Okay. And you see the flatten of the diaphragm. Hyperinflated lung on side. Associated with major lung collapse. Inhibited. Faulty position. So when you intubate, aku tengok sekali je kalau aku tengok lung collapse ni, aku tengok commonly post situation. Bukan tak biasa jumpa dah kita. You work long enough, you'll see it. Yang ni, hospital intern. Yang ni, trachea duduk tengah, lung duduk tepi. What do you think? What is your differential diagnosis? This is total whiteout, right? Cause homogeneous, heterogeneous. Huh? Homo. So what did you think? Associated with major lung collapse. Major lung collapse. So you talk about the pleural effusion only. You have to tell me what the pathology is. Okay, there is total whiteout on one side of the lung associated with major lung collapse. Why do you see so? Trachea, immune central. Mediastinal, immune central. Real life case. Aku tengok juga patchy heterogeneous. It turned out that sometimes this is not because of the pneumonia. This is hyperemia of the non-affected lung in compensating for collapse. So all the perfusion goes to this side. So sometimes you'll see patchiness. Bukan pneumonia actually. It's similarly happening in pneumothorax. I'll see a lot of this. This what? Collapse. This trachea deviated to one side. Huh? Huh? Ada pleural effusion or not? Ada pleural effusion? Ada kan? Trachea deviated to one side, right? So it's the lateral side. So this is lung collapse. Elderly female lung collapse. You tengok sini boleh tahu dah. Ni right mainstem, left mainstem. What happened to the right side? Block. There's area of demarcation there. So something wrong there. Okay? Most commonly elderly will be tumor. Okay. And it's also hyperinflated one side. Lung is hyperinflated. Not to say increase in aeration, trachea deviated. I want to show you collapse of the lung. So differential diagnosis of, so in summary, differential diagnosis of lung whiteout is depending upon the trachea and the mediastinum. Boleh? Yeah, probably.
A 42-year-old female attends the cardiothoracic outpatient waiting 2 weeks for review, 10 weeks post lung cancer surgery. Unfortunately, her notes are unavoidable. She says she has recovered well from the surgery. On examination, she is afebrile and her saturations are 98% in air. There is reduced chest expansion on the right with no breath sounds and dullness to percussion. Examination of the left lung is normal. A chest X-ray is requested as a part of the routine post-operative follow-up. This is a rank X-ray of a 42-year-old female. Located. Takia is
This AP, PA, right? PA. RIPE is rotated inspiration, penetration, exposure. Is this chest X-ray right or not? Masak tak?
It's not rotated.
Kalau ada rotated slightly to the left. Kalau ada. Sorry. Isn't it?
Rotated slightly to left. Adequate inspiration, exposure. Adequate inspiration and penetration, adequate exposure. Trachea is deviated to the right. Trachea is deviated to the right. Trainers.
Kalau komen pada next play, sudah dikerat. Sudah stapler ada. Stapler.
Unable to comment on the Carina's play. Unable to comment. Paratracheal stride is normal. Mediastinal osseous central not wanted. There's no upper lobe diversion. There's total whiteout.
Total whiteout on the right hemical.
The right
On the non-affected part, the vascular marking.
vascular markings, there's normal. There's no upper lobe diversion. No obvious consolidation or mass seen over the left hemothorax. No pleural line or no pleurotomy. No pleural. There's no blunting of cortopenic angle over the right, over the left side. Unable to comment on the right side. Unable to do the diagram. Unable to comment on cardiomegaly. Unable to
We all
visualize the heart.
you don't see the heart. This one, you don't see the heart. The heart menyosok ke belakang. Absence of any cardiac marking.
Unable to comment on the left hemidiaphragm, the right hemidiaphragm, sorry. Left hemidiaphragm, shaft with clear borders. No pleural effusion over the left. Express their staples seen over the right, right hilum, right medial side. Only border to be seen is the left hemidiaphragm, unable to see other three figures. Unable to comment on the right hilum, but left hilum looks
Cantik.
normal to state size density. No
Cantik.
lumpy bumpy hilum.
But the pinky or the pearl and the lutut. At one time, do you see the hilum very nicely? Is when collect. So you see nicely the left hilum. So the left hilum you tak nampak ke? You just vaguely see kan. Tapi you comment on normal section position of the. But this one cantik lah. Take her.
Image skeleton is to be intact, soft tissue.
Hidden area nothing lah.
Hidden area.
Apex nothing. So below around the hilum nothing. Below diaphragm nothing. Image skeleton looks okay. Was there any ribs missing? Okay, ribs intact.
Soft tissue under.
How they do it without doing a thoracotomy? I don't know. How they do it? I was expecting a thoracotomy wire. Across, or perhaps they crack the chest lateral.
What the fifth
Huh?
anterior rib looks cracked.
Right fracture.
The fourth and fifth anterior rib over
1,
the
2, 3,
bicep.
4. 1, 2, 3, 4. 5. This one. Is in here.
Oh,
4 and 5 ribs.
exterior rib.
Which one?
Anterior 3 dan 4.
Huh?
So
Anterior 3
4.
and 4.
Anterior 3 and 4.
No.
1, 2, 3, 4. Here. Huh? Ni.
Ah.
Ni.
Hmm.
Perhaps okay. Yeah. But it looks okay to me. I don't know, it looks okay to me.
Surgical clips, homogeneous ossification of the right hemithorax, expected position of right heart border, obscured right hemidiaphragm, tracheal deviation, hyperextended left lung, normal left hilum, expected position of the left heart border, and normal left hemidiaphragm.
Suppose saya pada ni ada orang patut lagi. Guna patut kan? Guna this back. This group. Guna this group. Saya pada guna. Saya pada
Gunangan Jawhari.
Hah?
Gunangan
Guna kerja hari. Dia kerja apa malam?
Kerja malam.
Malam dia kerja malam. Malam kerja malam.
Post night.
Post night terus balik Betul je. Tak tahan lah, tak boleh tahan. Balik terus.
Pneumonectomy, patient anonymous, projection PA, penetration adequate, reversible body space visible behind heart, inspiration adequate, 8 and greater ribs visible and not repeated. Airway trachea is deviated to the right. Breathing, there is a white out of the right hemithorax with a total absence of bronchosvascular markings. The left lung appears hyperexpanded but clear with normal pleural spaces and pulmonary vascularity. Circulation, the heart is difficult to identify. It is presumably displaced into the opacified right hemithorax. The mediastinum is displaced to the right. The aorta is difficult to identify. The right hilum is difficult to identify due to the opacification. Normal size, shape and position of the left hilum. Diaphragms and delicates, the right hemidiaphragm and costophrenic angle are obscured. Normal appearance on and position of the left hemidiaphragm. No pneumoperitoneum. The image skeleton is intact with no fractures or destructive bony lesions visible. The visible soft tissues are unremarkable. Expressed in preview areas. There are surgical clips projected medially over the right hemithorax near the trachea and right main bronchus. No vascular lines or tubes. Lung apices, opacification of the right apex, normal left apex. Right hilum difficult to see, normal left hilum. Behind heart difficult to assess and costophrenic angle obscured on the right, preserved on the left, below diaphragm normal.
Okay. So total whiteout lah. Okay. This X-ray demonstrate a total whiteout of the right hemithorax with marked volume loss. Demonstrated by the standard deviation, tracheal deviated, right heart, the heart is actually already go to that side. There is surgical clips in the right mid and uppers suggestive of surgery. The findings are consistent with the normal appearance of right pneumonectomy. The whiteout will be due to fluid filling the post-pneumonectomy space. The whiteout will be due to fluid filling the post-pneumonectomy space. There is no airfluid level hydropneumothorax suggests a bronchopleural fistula. Kalau ada airfluid level, hydropneumothorax suggests a bronchopleural fistula. It will be helpful to compare the cardiac X-ray with previous imaging. No specific investigation is required. So pneumonectomy, 242. Let me see. Oh, easy peasy. Yeah, exactly.
A 65-year-old given presence to GP with worsening shortness of breath. She has a 30-pack beer smoking history and has a background of recurrent pneumonia. On examination, she is a pyrexia, 38.5 Celsius, and her saturation are 98% in air. There is reduced air entry in the right mid-lower zone with dullness, percussion, and occasional crackers. A chest X-ray is requested to assess for possible malignancy, collapse, or consolidation.
Easy peasy.
This is anonymous chest X-ray, PAU, not updated, good inspiration, good penetration, subocular exposure. Trachea is central, no paratracheal thickening, carina not split, mediastinum is central, B normal glomeruloscopy marking, right side air space opposite of right lower
You
zone.
can say a triangular shape as space of classification. And also a classification that obscuring the right diaphragm. The guy came in with temperature 38.
No microcostopenic angle and no pleural deepening. No cardiomyopathy and unfolding of
Unfolding of the aorta.
Obliterator of border of right hemidiaphragm. No air under
Medial, you can say medial part of the.
right hemidiaphragm. And right hemidiaphragm.
And right heart border, you think?
Obliterated
Of
also.
the protein also.
No air in the diaphragm, and then right hemidiaphragm higher than lower hemidiaphragm, which is normal. And then no extra C. Next. Right arm border is obliterated, otherwise left and left hemidiaphragm is clear. Right hemidiaphragm is obliterated also, middle part of right hemidiaphragm. Gastric bubble C. Hilum, right side hilum is normal in shape and density and position also, it is lower than left side.
Good. Hmm?
Hidden area. Hidden area. All normal. Retrocardia, retroviral.
See, the lung marking extend beyond the diaphragm, you see? So, this is base of the lung. You know. Okay, I'll keep telling people we're missing a lot of this opacification. They stop the diaphragm. Actually below here also.
Below. See, gastric bowel C. And image skeleton soft tissue on animal.
Mana? Ni apa dia ni? Nak boleh alimah ke apa? Apa dia ni? Oh, fracture. Clavicle. Mana kalau normal ni? Oh, fracture ni. Oh, fracture. Ni, you nampak dah ni? Ni dengan ni. What do you think? I don't know whether you see or not. This. And this. What is this? Huh? Yeah. I think it could be a nodule, but you have to. Kalau you rasa suspect nodule, because I nampak macam nodule kan. When I saw it, I thought I suspect a nodule here. Though I have to go and ask they have a nipple marker. They put the nipple. It could be a nipple. The image skeletal, fracture, soft tissue, lady. Is this a complete audio? No, this is probably knee problem. This or this? Okay.
Apparent fracture relation due to patient rotation, whole displaced clavicle fracture, partially obscure right heart border, triangular area of ossification, normal right hemidiaphragm.
Macam mana normal right hemidiaphragm? I don't know. You go contest this book ah. Aku dah puati habis tu.
Patient rotated to the right, whole rib fracture.
Oh, ya. Nampak whole reflection. Yalah. Reflection kan? Ya, ya. Oh.
Clear left lung, unfolded thoracic aorta, clear left heart border, normal left hemidiaphragm.
Yeah.
Right middle lobe consolidation.
Yeah, the middle lobe consolidation.
Patient ID anonymous, projection PA, penetration adequate, vertebral body just visible behind heart, inspiration adequate, if anterior ribs visible, rotation the patient is rotated to the right. Airway, the trachea is central after factory inpatient rotation. Breathing, there is triangle area of ossification medially in the right lower zone adjacent to the right heart border. The horizontal fissure is not visible. The remainder of the lung are clear. The lungs are not hyperinflated. Pleural space are clear. Normal pulmonary vascularity. Circulation, the heart is not enlarged. The right heart border is slightly indistinct. The left heart border is normal. The descending aorta is unfolded. The mediastinum is central. Normal size, shape and position of both hilum. Diaphragm and varicates. Normal appearance and position of the hemidiaphragm. No pneumoperitoneum. There is an whole displaced fracture of the distal right clavicle and whole fracture of left fourth rib posteriorly. No other body changes. The visible soft tissues are unremarkable. Extra cerebral areas. No vascular lines, tubes or surgical clicks. Lung apex normal, hilum normal, behind heart normal, postophrenic angles normal, below the diaphragm normal.
So the middle lobe consolidation, you will be obscuring the right heart border. The reason why they say there's no definite volume loss, if there is a volume loss, you suspect what? The middle lobe collapse. The middle lobe collapse is paling susah sekali detect, to be honest, because it's so subtle. One of the clues is the middle right border of the heart is obliterated. Another one is the hilum, the right hilum tak nampak, dia pergi menyorok belakang heart. Collapse. The rest just like consolidation. So the word there's no definite volume loss is just to infer that there is no collapse. Okay? Because distinction between collapse, the CT of the chest will differentiate between collapse and pneumonia and could demonstrate another cause. This is what they are saying. Okay? This X-ray demonstrates approximation immediately to the right mid-zone obscuring the right heart border. There is no definite volume loss. The most likely differentials are right middle lobe pneumonia or collapse. Okay? When you see this, you will say, was it collapse or not? The clue is volume loss, crowding of the ribs, the hilum. Initial blood test may include full blood count, UNEs, LFTs, bone profile, ESR, and CRP. Previous imaging should be reviewed to determine if this is a new finding. A CT of the chest would help differentiate between collapse and pneumonia and could demonstrate an underlying cause. Okay? Because if it's collapse, then you have to know what is the reason for the collapse. Intraluminal, extraluminal. Most commonly still hilum mass or intraluminal endobronchial tumor. Okay, the collapse of the middle lobe on the horizontal, on the frontal chest X-ray. Macam mana tau dia punya collapse? Blurring of the right heart border. The density in the collapsal lobe may be always very subtle. Okay. Of course, you've got other volume loss features like elevation of the right hemidiaphragm, crowding of the right side of the rib, shear from the sternum to the right. So, dia macam ni je. Macam ni je. Right. And on the lateral view, you nampak macam ni lah. Okay. So this is example, the middle lobe collapse is evident when the two views are assessed as paired. You suspect this, I suggest you take lateral view. Okay? You can see this kind of mulut intake kind of appearance here. So the middle lobe collapse is not common, but the missing part is when you see, you want to say the middle lobe pneumonia, the teaching embedded here is sting collapse. Wow. When you say, there is a middle lobe pneumonia, wait. Is there any collapse? Because if collapse, it infers something dangerous, more dangerous, like tumor. Aku tengok yang pregnant lady, Indian pregnant lady who came in Mirachi ni, in York. Right after lobe collapse, with middle lobe collapse as well, with status asthmaticus. So you or who? Ayuni. So they got upper lobe collapse, also the middle lobe collapse. Slice of cake. Start with 43. So ada 7 ya. 7 lagi, hopefully by one class or one two classes. 50. Then we'll go to plain and brown lines. Another 50. After that we go to image. Another 50. The rest of you teaching clinical, you go to other. Aku suka latih to be on part. Though I would like to talk at least 2 hours talking about COVID, but listening to the lecture from YouTube. Let us listen together. Aku suka je you got 2 hours. 1 hour listening to ADHKL punya lecture, another 1 hour listen to one lecture. So this will you consolidate the knowledge when you get COVID. Easy lah, okay? Just like dengue as well. When you are not, ED bucket should be good with dengue and also good with COVID. Unfortunately or fortunately, you are not managing COVID as much as those who are managing COVID like that. Unfortunate or fortunate? You don't feel the pinch, did you? Did you feel the pinch? Huh? That's it. You feel the pinch. The pinch.